This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Is there a DPC clinician, tech vendor, or industry champion that goes above and beyond to further elevate the DPC movement? Nominate them for a DPC Innovation Award to recognize them for creating traction, embracing innovation, and demonstrating commitment to the movement. DPC Innovation Award winners will be announced and honored at this year's Hint Summit, taking place in Denver, Colorado, September 27th through 28th. Nominate a DPC innovator at summit.hint.com, plus get $50 off your Hint Summit 2024 registration with promo code MyDPCStory. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, patients pay their doctor a low monthly membership and, in return, build a lasting relationship with their doctor and have their doctor available at their fingertips.
I'm providing a more convenient, personal, and accessible approach to your care. This is Dr. Dhrupad Joshi of We Care Neurology, and this is my direct care story.
Dr. Dhrupad Joshi is both board-certified in neurology and psychiatry and fellowship-trained as a clinical neurophysiologist. He graduated from UCLA with a Bachelor's of Science in Biochemistry and then went on to medical school in Las Vegas, followed by residency where he served as chief resident in neurology before his neurophysiology training at UCLA. During his residency and fellowship at UCLA Harbor Medical Center, he developed additional expertise in headache and epilepsy disorders. He is an assistant professor in the Department of Neurology at California University of Science and Medicine, and also serves as a medical director of the Neurodiagnostic Lab at Arrowhead Regional Medical Center. Dr. Joshi treats many diagnoses, including some of which he'll touch on today, such as seizure disorders, headaches, and movement disorders. He opened his direct care practice in June of 2020. Welcome to the podcast, Dr. Joshi.
Thank you.
You are the first direct care neurologist that we've had on the podcast. And I wanted to ask you, how did you come to learn about the direct care model?
Mainly from the social media websites, Facebook and Instagram. And I have been known about the concierge practice, which was also cash-based, and they also take insurance. But then doing research with that, I found out that there is something called direct care practices and direct primary care practices that runs on a membership model. So that's how I came to know about it.
Social media is definitely helping the movement of direct care and direct primary care to build a stronger following and to encourage people to leap into direct care. When you chose to create a direct care model clinic, did you switch to cash pay only or hybrid? What was your transition like?
So my initial goal was to open up a side private practice because I'm an employed academic neurologist and I do work for a medical school here. But I want to do something on my own because of the COVID. A lot of people are getting laid off and there's no job security even for the doctors. So I decided to open up a private practice on the side, and my goal was to be independent of any organization, especially the insurance contracts. So I decided to open up cash-only practice in my neighborhood, which is considered suburbs of LA. It's called Inland Empire, and it's considered a poor neighborhood where 90% of the people are on HMO or Medi-Cal. So it's more of an experiment at that point when I started thinking about it. But I was very excited to do something on my own because I always wanted to do something on a business side on my own. I never thought I'll do the medical clinic practice, but here I am now.
Well, that's wonderful. And just that motivation to provide care to the Inland Empire, where you mentioned, Medi-Cal and HMOs are the majority of the patients there. So, on that note, when you are taking care of a population that is heavily based in Medi-Cal and HMOs, are you seeing pathology that you might not see in a clinic where there is private insurance?
Yeah, usually people who don't have great access to the insurance, their care is often delayed, and by the time we see them, they're already in their advanced stage of their neurological disorder. So we see them at their advanced stage and at the point where they need a lot of care on top of just the neurological care. They just need a lot of help at the home health care and stuff like that. So yeah, I'm seeing more severe cases in people who don't have good access to the medical care because they just couldn't go to the doctor, and even if they go to a doctor, it's just a very long wait, and most of them are seen by the primary doctor or PAs and NPs, and even they don't like to refer to the patient right away because they are. I think if they are on HMO contracted insurance, it's kind of looks at them negatively if they refer a lot of patient right away.
On your website, you list Reimbursify as a service that patients can use. So can you tell us a little bit about Reimbursify and how that works for your patients who do use their insurance for your
So it's a
practice?
third-party company. They basically submit a claim on your behalf. So what I have to do is I give the patient super bill, and from that super bill, the patient just upload all the information, or basically they just scan that receipt, and that Reimbursify website just submit it to their own patient's insurance, and they deal with all the rejections and everything. So it's a good service. First one is always free for the patient. The more claims they submit, there is some fee that patient has to pay. I don't have to pay anything. It's purely the patient choice. They can directly deal with their insurance companies as well if they don't want to use this Reimbursify service.
In your patient population, have you seen most of your patients use the Reimbursify
Not
service?
really, because so far I have had one patient who used it, and I don't know if it's they got the reimbursement right away or not. But most of the people they just don't submit it to their insurance, and most of the people don't have uh, the private insurance that they can submit. So I'm seeing a lot of uninsured HMO patients, and also a lot of Kaiser patients for surprisingly because they have a big net. Kaiser is a big network, but still I'm seeing a lot of Kaiser patients. Most of them that I see it's because of the poor access that they have. Usually their appointments are weeks or months behind, and they wanted to get the answer right away. So that's where I can see them within 1 to 2 days.
That access is fantastic. When you are working with a Kaiser patient, does that patient need to get an approval through Kaiser first before they see you, or are they able to
No, they can
self-refer?
self-refer because this is like me. I'm not part of Kaiser, so to me, they are just a cash patient for me.
When a patient is contacting you, doing a self-referral and doing a telemedicine visit, do you have them fill out a form prior to your telemedicine visit?
It's basically a Google form that I have created, and basically has all the information about their demographics, past medical conditions, insurance information as well, their primary care doctors, and most importantly, there is also a payment information that they have to put in their credit card or debit card so that we can use that for the fees. And once we receive that form, after then their appointment is considered confirmed. Until then, it's just a tentative appointment. So that way, I have been able to manage having 0% no-show rate, because when they do fill out the form and put in their information, and we charge actually at the time of booking. So let's say if they're booking today for tomorrow or day after tomorrow visit, we charge today when they fill out that form. That way I had 100% show up rate, whether it's a telemedicine or in person.
Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes. When you look on your transition from the fee-for-service world, the academic portion of your career, and your transition to offering direct care services, what are challenges that you see specifically for neurologists who are thinking about entering the direct care model as well?
I think I would say it's a little hard for the specialist to do a direct care model. When I say direct care, I'm talking about the membership model. Because for example, if I were the patient, I wouldn't sign up for a membership to a specialist who will only treat one or two neurological problems. I would rather have someone like a direct primary care where they can deal with all the problems I have and refill all the prescriptions, versus specialists who will only manage the specific specialty problems. So that's why I have been open for 5 months and I have not seen that many members who signed up for it. I'm seeing steady increase in one-time or two-time follow-ups patients where they just pay out of pocket and then that's it, and then they just go back to your primary doctor and take care of the other needs there. So in terms of membership, I think it's going to be a little challenging for the specialist. Initially, I thought that a lot of migraine patients and seizure patients will need an ongoing care, so they will sign up for a membership. But it turns out that I had a couple of migraine patients. They did sign up for a membership, however, but when I started the treatment, they got better, and then their migraines are gone. So they're like, okay, I'll just keep taking this medication. I don't need to be seen very frequently, so I don't need a membership.
It's a very important point, though, for others to hear, especially if they're specialists considering entering a direct care model of any sort, just because so much of the movement is focused on direct primary care. But when we are encouraging and wanting and hoping for specialists to join the movement, it's something to be cautious about and something to develop your practice around the knowledge of. So I'm really glad you mentioned that, because as we all hope that, neurology, rheumatology, dermatology, other specialists will join the movement and help perpetuate the idea that, care is accessible. 1 to 2 days for a patient to get in, it's just unheard of in my fee-for-service clinic. So that is just amazing that you're able to offer that access for a cash pay patient, as well as those who do use their insurance. Do you have an office location?
So starting next month, I'm going to have a physical location. Until now, I was subleasing an office. So yes, in that sense, I did have a physical location for all that month. But I was using someone else's exam room as needed.
How did you find the person to sublease to you, and how long was your sublease for?
It wasn't really any contract. It was month to month to begin with. It was only $400 a month for using maybe 8 hours a week type of exam room. And I just drop in. I just go there and use it whenever I need it. There was no time limitation. And the way I find it is I reached out to a local physician group or society and emailed him that if he knows someone who's looking for a person to sublease their office, let me know. And he gave me a couple contacts, so I just picked one of them. It was pretty easy. That was the easiest part in the whole process.
When I Google your name, the address that pops up is in San Francisco, but physically you're in Southern California. Can you explain how you have multiple addresses?
The reason I have different addresses is actually for marketing purposes. So I had two options when I was looking into the marketing, either pay a lot of money to Google, so people who search for neurologist, I'll show up there. Even if people search in the Bay Area, I'll show up there as a neurologist from Southern California. But then people not gonna click on my ad to see a neurologist from Southern California. There, everybody's looking for a local neurologist. That's what I figured. All the patient is looking for a local doctor. So having a actual address is helping me to over time build my presence in that area. So like you looked up my name and you only saw Bay Area, right? And I'm not even paying money to show up there. It's just having my local address there. It's making a big difference.
How do you manage the local address?
If you know someone who has a medical clinic and if they agree to use their address, I mean the thing is I did find a neurologist in Orange County here who agreed to have me use their office address. So I have that in Tustin is one of the location, and that's like it's been 4 months now. I haven't heard from her. I haven't contacted her either. It's just I'm using her address. There's no agreement or anything. She just wanted to help, and yeah, if you know someone and who's willing to help you get the address, use the address for your website just for marketing purposes, that would be great. If not, the other option is you can pay for virtual office address. See, the patient that I saw from Bay Area, they don't even know that I am in Southern California. They just think I'm in
Yeah.
Emerald, somewhere in Bay Area there.
That's so funny.
So that's why I have a toll-free number, so they wouldn't know where I'm physically located. Otherwise, people might be skeptical, like why I'm seeing a neurologist all the way in Southern California when I can find someone here or something like that.
I've never heard of someone doing that.
In like a month or two, I was pretty easily searchable by the patient in the local area. Then I told my brother who made my website that how do people find me in LA or somewhere, and he said we can put some keywords about LA and San Francisco there, but people were not really finding me in those areas. So I figured that having a local address will improve your local presence on Google, and that's what I did. So that's how I'm getting, and that for that I need a local address. So which either I pay or find another doctor who can collaborate with me. So for example, if I'm going to a different state, let's say if I only have a California license, but I was thinking of getting a Texas license. In that case, I'll probably get a Dallas physical address. That way, they find me a local neurologist in the Dallas area on their Google map, because everybody is searching on a map nowadays, or just simple Google. And Google Map is a whole different search and SEO marketing as compared to Google.com. And I'm focusing more on Google Map because when patients look for it, they look for a geographic region.
Earlier, you were mentioning that one of the easier parts of the process was finding a location and creating your addresses. What was one of the most difficult parts of that
Getting
process?
the corporation made. California is very tough to get this corporation application and everything, and getting the tax ID and everything, because I had a problem where my business name is We Care Neurology and INC at the end. So in the tax ID, there was no INC, incorporation, at the end. So that's a mismatch of the name. So that took more than 6 months to fix that from the tax purposes.
How frustrating. Did you end up fixing that on your own, or did you have legal help?
No, it was on my own. Basically, the process was simple. Just send them a letter saying what I needed. So I did. It's just waiting for them to process that was the longest.
I can imagine the process took longer just because of COVID. In terms of your offerings, you offer both telemedicine and in-home services.
So when I started, I wanted to do in-home, but then I decided I don't want to do it because of the COVID, and also in this many months that I have been open, I have not received any request for in-home visit. So I feel like it's not that many people do or expect. So it's on there on my website, but I haven't able to do it.
What does a telemedicine visit look like for both you and your
Actually,
patients?
it's pretty good. A lot of people like it. I have been seeing a few patients from Bay Area as well through telemedicine, and it's basically I'm using Google Meet, which is through the Google Suite, which is HIPAA compliant. So people like it most of the time. I mean, I would say 95% of the time you don't really have to see the patient in person because you can pretty much do everything through virtual visit. So people are liking it. Even right now in my local area where I do have an office, I only see them one time in person as a new patient, and rest of the visits I do encourage them to do follow up as a telemedicine visit.
Depending on what you're treating, do you have a set schedule for follow-up for particular diagnoses, or how do you determine your
No, it's
follow-ups?
usually I have a few hours set aside for my own clinic because also have a full-time job. For new patient, it's 1 hour. Follow-up is 30 minutes, and however they wanted to make an appointment. So I don't have a set schedule for news or follow-ups or any specific disorders or anything.
In terms of specific services that you offer, like Botox, how does that work for a patient who might need that service and they're geographically farther away from you? Do you have people that you refer them to if they do need a procedure where you can't physically
So it
see
really
them for?
depends on how much they want to travel. Not yesterday, just last week, I saw a person who traveled 70 miles from Newport Beach to me, also from a very concentrated, physician concentrated area, all the way to me for a nerve conduction test. So I guess if they're okay traveling an hour or two, then they're welcome to get the procedure done by me. If not, then I'll just refer them to a local neurologist over there who does that procedure.
What about for imaging and medications? On your website, you mention that patients can potentially get an order for something like an MRI and not necessarily have to pay a membership fee or a visit fee. Can
Yeah,
you
so
can
it's
you
more
expand on that, please?
there are a lot of telemedicine doctors who will give you a refills if you're running out on medication for a minimal fee. So same thing I have. Basically, if someone wants to get an MRI of the brain, if they're curious of something, or if they want to get an MRI order or CAT scan order or anything without a formal evaluation, I'll just write that down for them, and there is a small fee for that as well.
And that prescription, say for an MRI, is it for a negotiated cash price that is lower than what typically insurances
Yeah,
will
so I didn't
charge?
really negotiate any prices. I think the prices that I found is pretty reasonable for the services they offer. So what I did is, in my neighborhood, I just called up a few imaging centers and asked them their cash discounted price, and I picked the one that has the lowest and put that up on my website. So if someone asks me for that pricing, I'll just refer that patient to that specific imaging center, and they usually can get the patient in also within 2 days because they don't have to get any approval or anything, and they just pay up cash.
What about the Bay Area folk? Do you have resources for them to use a prescription for an image to get a discounted
So it
price in the
depending
Bay Area as well?
on their insurance, as it most of my patients, 70% of them I see or has some kind of insurance. Only 30% are like without insurance. So for them, I just tell them that just look up imaging centers and ask them for the cash discounted price for the Bay Area. And if they have some kind of insurance, I just tell them that to ask your primary doctor to order that, or they can just take my orders to the imaging center that they usually go and have the imaging center bill the insurance on their behalf. I have not had any issues with that process so far.
I want to go back to, you mentioned that you have a full-time job in addition to We Care Neurology. So can you share with us, what does your typical week look like in terms of balancing your full-time job, We Care Neurology, and family life?
Full-time job, I'm an academic neurologist here in Inland Empire. Usually it's an academic, so I basically oversee the residents, medical residents and neurology residents. So they see the patient. All of our clinic are also virtual visits. So basically they're calling the patient and then calling me to staff, and then they call the patient back for any updates. So that's how it is now every day. I also do 3 days of procedures, mainly nerve conductions and EMGs. at the academic center, which is 3 half days. So the rest of the days, free to see my own patient. I might get a call intermittently from residents to staff a patient, but that's pretty much it for the academic work. Social life is pretty low right now because of the COVID. We haven't been traveling for a while. So we are, if anything, we just go nearby to the beach and mountains. We haven't done any domestic flight or anything. Other than that, my wife is a part-time at Kaiser, so she has a pretty flexible schedule. So I would say the work life and social life and personal life, they're all well balanced right now.
You mentioned your wife is doing part-time at Kaiser. Has she ever thought about, or have residents that you're working with ever thought about jumping into the direct
So
care
residents,
model
I
as
try
well?
to educate them about this model as whenever I get that opportunity. I was surprised that I was working with the family medicine residents and they never heard of this term. So I literally had them Google it and look into it, even though they've been going to the family medicine conference for a couple of years. But yeah, it's direct care and direct primary care is not very popular. Not a lot of people know about it. So I think educating them is one way to go to increase DPC practices in our country. I don't think my wife wanted to do anything to do with the business. She doesn't, she's not a business oriented person, so she will just work part time. And I think she's pretty happy with the Kaiser right now. And she's only working part time, so her schedule is pretty good. It's like every alternate day, so she not gonna do DPC. I asked her if she wanted to DPC and me as a specialist. That would work out really well for the patient, but so far no.
And that's okay. It is great though that you are, even as a specialist, you are sharing the world of DPC with family medicine doctors. I definitely hope that there is a transition as the movement grows, that you won't have to, have blank faces staring at you when you mention direct primary care. But that's great that you're taking the time to educate them. You are a DO by training. Do you use osteopathy in your
Actually, I
practice?
would say OMT was a part of my medical school training in the first 2 years, and the third and fourth year was clinical. So I only studied osteopathy for my board exams. As soon as I'm done with my medical school, I entered into the ACGME residency and fellowship. So outside of my medical school training, I have not practiced OMT.
Earlier, you mentioned doing EMGs and a patient traveling 70 miles to see you for one. In terms of the equipment that you have, can you tell us a little bit
For
about
the
your equipment
EMG
that you
nerve
use for
conduction?
that?
Yeah, I mean it's a very popular equipment made by Cadwell. Usually, new one costs about 15,000. Used one you can get it around 9-10,000. It's pretty good equipment, and I would actually encouraging when I was working with the family medicine residents to learn about the nerve conduction test because usually those are done by the technicians, and there is a nerve conduction technician schools out there. Physicians are needed for EMG to evaluate further. However, nerve conduction tests can be easily be done at bedside by primary care doctors, and I think they used to do it in the past for evaluation of carpal tunnel, cuboidal tunnel, and Guyon's canal problems and stuff like that.
I want to go back to primary care doctors doing the procedure. So I know that there was a brand, Neuromatrix, that was offering an in-office point of care EMG nerve conduction study kit for carpal tunnel and other EMG testing. Do you know of how useful that device is, or other devices that are more user friendly or cost friendly for a primary
I don't
care
know how much
office?
it costs though. I did look into it, but it's very limited to evaluate for, let's say, carpal tunnel or tarsal tunnel. I think that's what it has on the picture. So I think this machine is pretty good who just wanted to check one nerve, but I think as a primary care physicians, if they learn a bit more, and like when you do get a patient for carpal tunnel, you do want to make sure that there is other nerves that are normal and it's not the peripheral neuropathy on top of carpal tunnel and stuff like that. So I don't know how good is that machine for evaluation of those kind of stuff. But I would say if primary care doctor wanted to do these procedures, they are more than welcome to do it. It's super easy to check for three nerves that we usually do, and then these reports can be interpreted by a neurologist or by a psychiatrist remotely, because these nerve conductions are done by, as I mentioned, by technicians. So they are not even a doctor. So if a doctor does it and then have the report interpreted by a neurologist, that would be one way to go with it. That way, patient doesn't have to travel far away or wait for a neurologist to do that procedure. EMG is complicated. I think for EMG you have to have a special neurologist to do it. But I think most of the cases, even right now when I'm working at academic centers, 70% of my cases are carpal tunnel and cuboidal tunnel. So for those people, I don't even do EMGs if the nerve conduction and their symptoms are slam dunk for that particular diagnosis.
For a person who might be in primary care and interested in doing nerve conduction studies, do you have a specific recommendation for a place that they can learn from?
Per medical training that does a 2 or 3 days boot camp type of course for nerve conduction EMGs, and I looked into it. A lot of mid-levels are doing that, and I think part of the reason is they wanted to start doing this procedure in their office. So I rather have a physician start learning those techniques, and it takes more than a couple days, but over time it's not something that you need a 1 year of fellowship for it, which I did. But then my fellowship also includes the EMG and EEG part. But if it's just a nerve conduction studies, I think if you spend couple days a month with a neurologist for maybe 3-4 months, you will be pretty good at diagnosing all the mononeuropathies and peripheral neuropathies. And in that case, I would really encourage primary doctors to start doing that, because one is not many people are doing it. Even if you are taking insurance, it pays pretty well. Even if it has decreased in reimbursement, it does pay anywhere from 200 to 400 depending on how extensively you do it. But I think for the access to care reason, I think primary care doctors should start learning it and start doing it. And they should actually buy or at least rent the actual whole equipment where you can do more than a neurometrics, I think, which might be limited to few diagnoses.
We don't see a lot of specialist tools on DPC Docs or Direct to Primary Care Facebook pages. So that's great that you mentioned this Empire Med training. And I'll be sure to put that link on the blog. I have become a huge fan of podcasts. Ever since Sarah Koenig hosted the first season of Serial, I was hooked. Now, creating this podcast has become part of my daily life. While it is an exciting new hobby, I also see it as a privilege that I get to interview so many DPC and direct care doctors. If you are interested in starting a podcast, let me tell you a little bit about Anchor. First of all, it's free. There are creation tools that allow you to record and edit your podcast right from your phone or computer. Anchor will distribute your podcast for you so it can be heard on Spotify, Apple Podcasts, and many more. You can make money from your podcast as well with no minimum listenership. It's basically everything you need to make a podcast all in one place. Download the free Anchor app or go to anchor.fm to get started. With regards to demographics for your patients, you see 12 years and older.
Anyone about 12 I don't think we have to do the pediatric dosing by the weight base, so we can just do the regular adult-based dosing for them, unless they are super skinny and very low weight. And so I figured why limit myself to 18 and above? I can still do 12 and above, and there's still no difference in diagnosis and treatment at that point.
Do you use a particular direct care EMR, or what
I would say I'm paper chart right now. I just chart everything in the computer, make a PDF file, and store it in Google Drive for now.
Do you have a particular communication platform that you use separate from the Google Hangouts for patients to potentially text you?
EMD app for text message communication with the patient for members only, and for everyone else they can just call us or text us at my business phone number, which is through Google Voice.
I'm assuming you have Google Suite with a BAA. Yeah. Have you experienced any pitfalls with using Google
No, I have no
specifically?
issues with them. In the past, when I was using the Google Voice app directly, I was getting a lot of drop calls. I guess it's because of the connection issues. But now I have all those calls get forwarded to my cell phone, so it's just a regular phone call. So it's working fine. I have no issues with the Google Voice so far.
Do you have any other tech or tools that you use in your practice that a direct primary care doctor could also benefit from using? Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited, customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad.
I do injections for, let's say, migraines or occipital neuralgia, trigger point injections, which I think all primary care doctors can do as well. Some people have excessive drooling, so maybe they can do Botox injection in the parotid glands, or excessive sweating in the palms and armpits. So I guess it's all again Botox injection. So those kind of stuff can be done by anyone, by primary doctor as well. In terms of doctors who might be looking to add that type of service and value to their clinic offerings, do you have a resource that you recommend people to check out in terms of training for Botox for those procedures? If you just look at the educational videos, you will get hang of it. It's not that complicated. If you wanted to see firsthand how it's done, I think it's easier to reach out to a local neurologist who are doing it and just shadow him for one or two procedures. But those procedures are very benign and it's pretty simple. So I'm sure there is a training out there. Probably this Empower Medical Training maybe offers that as well, but I don't know about any other institution who offers it as like a formal training. I have a patient who travels 3.5 hours to go to UCSF for Botox injections for her migraines. It had not been offered locally until there was a doctor who left who just came back. But that's what we typically see is literally people are driving hours, just like your patient did to see you for the EMG to get Botox. So that would be wonderful if a primary care physician were able to add that. It's actually safer for migraine because you're not putting too many on the face. You're putting more injections on the head. So it's not, I think they should. In my training, actually, we were training primary care, family medicine and internal medicine residents as well. If they're interested in doing Botox, we had a headache clinic and they sometimes get to do those injections. Where the direct primary care movement has organizations like the DPC Alliance, is there a similar organization for neurologists who are joining the movement of offering direct care to patients? I'm not aware of any. Hopefully that changes in the future, but it's good that you're part of the statewide DPC movement to stay informed on trends and changes in DPC and direct care, but also to help develop your own practice. Yeah, I looked into it, see if there's any direct specialty care kind of Facebook group or something out there, but I didn't find any so far. I definitely would encourage, if there are any specialists in neurology specifically, to reach out to you to potentially create something that might not be state-based, but could potentially be nation-based. That would be awesome. On that note, what is the best way for someone to reach out to you if they wanted to ask you more questions? my toll-free number at 855-220-1777, or they can reach out through my website at vcareneuro.com, and there is a contact page at the bottom of the homepage.
Is there a particular way that you would guide a primary care doctor differently in a common thing like headaches or seizures
Especially for
improving on?
seizures, if patient is on at least two medication and not having well-controlled seizures, um, they should be patients should be referred to a tertiary epilepsy center for surgical evaluation of epilepsy. And also, if someone just has a history of epilepsy, primary doctor should have the neurologist manage those seizures, even if they are not a surgical candidate. I see some primary doctor manages the seizure on their own without referring to a neurologist. And sometimes what I see is that patient is on a medication that conflicts with other medication that they are taking, and that way the medication are not as effective or maybe having a lot of side effects. So seizure is one of the things that I would highly recommend the primary doctor to refer to a neurologist right away. For migraines, I guess if it's controlled, then no need to be referred to a neurologist. But maybe when it's not controlled, it would be better to have maybe at least have a virtual visit with a neurologist, so you have a plan of treatment or action that they can follow up on after that. What I have noticed that headache is one of the symptoms or migraine that people don't usually doctors don't take it as seriously, because obviously it's not going to kill the patient, but it could be very debilitating for the patient that they cannot work, and it really affects their social life. So even if it's just a headache, it is affecting them. So treating it effectively is very important.
Is there a particular for those in primary care, do you recommend any specific resources in terms of excellent questionnaires or excellent videos that you have your own residents
Um,
pay attention to?
not particularly. Basically, I go with the case by case basis. I usually try to treat them what they should do before referring to a specialist, and what they should do when to refer. Those are the two main questions that primary care doctor needs to know, so that they don't delay care for the patient, and the consultation happens on a timely manner. So I think I focus on those things rather than actually teaching on how to manage an epilepsy, because at some point it will be if a patient is having complex epilepsy problem, then it might be out of their comfort level to manage on their own.
Definitely, especially if you're looking into a tertiary center and intervention. What about when it comes to movement disorders? What is your advice with regards to primary care and handling movement disorders like tics, Parkinson's,
I would say movement
before
disorder
referring to
is the
neurology?
most complicated field of neurology, um, because it just takes way too much effort to make someone's lives better, because those problems like Parkinson's and tremors and whatnot, those are progressive disorders. So it doesn't matter what you do, they're still gonna get worse. And at some point, they will need multidisciplinary approach, and they're gonna have multiple multi-system problems. For example, in Parkinson's, they have stiffness, memory issues, agitation, depression, urinary incontinence, and all kinds of systems are affected. So it gets very complicated even for neurologists to treat them. So I would say if you refer a patient early, it's better, because the earlier is sooner, especially in movement disorder world, because we can slow down the process. If we get the patient who are already in a moderate or severe severity or the stage of their disease, then it's too late, and we have very limited option on what we can do to help them. So sooner is better, because that's how we can slow their progression um, by how many years, depending on when we effectively start treating them.
And that goes back to your patient population. If a patient has a delay in care just because of their insurance or lack of insurance, I can only imagine the situations that you found yourself in or your residents have found themselves in.
It's not just tremor. They will have stiffness and they have slowing, and which you people cannot notice in their 5-10 minutes visit with the patient if they're in a fee for service clinic. So a lot of time it's you miss the symptoms until they are severe and they start falling, and then they're like, why this falling, and then they get all kinds of cardiology workup even before they consider neurology. So far I have seen that all the patients that was referred to me, they're in a pretty severe stage of their disease by the time I get to see them. It's not because if one thing is primary care in 5-10 minutes visit, you may not even to pick up the small findings that patient has in the beginning, and by the time we notice them, they're already kind of in a moderate severity, and with the approval and prior authorization, referral takes another few months. So it's better to look for those kind of signs and symptoms and refer them earlier than sooner for better outcome.
No, that's so important that you mentioned that. As a doctor who's been in practice for 5 years, I appreciate what you're saying immensely. I have a dear patient of mine, an older lady. She's in her 80s, and progressively over 5 years, I've noticed her changes, but I also typically spend 45 minutes with my patients. So that is so important for doctors to hear, especially those who are doing direct primary care and who have the time to know, build a relationship, and can pick those things out from a patient just by knowing them over time. It's sad that that's been your experience, but it definitely speaks to why direct care and direct primary care is so important. Thank you so much, Dr. Joshi, for joining us today.
I'm happy to be here and continue. Hopefully, I can continue doing this. And hopefully my private practice job can grow to the point where I won't be relying on my academic job as much.
Next week, look forward to hearing from Dr. Kate Snodgrass of First Primary Care. If you like what you heard today, please leave a review and subscribe wherever you listen to your podcasts. Tell your friends too. For more information on this episode and much more, please visit mydpcstory.com. Until next week, this is Marielle Concepcion.